Hello, everybody. Thanks so much for coming along again. We've got a really interesting talk this week looking at social factors. So as ever, we'll just give it a couple of minutes for people to filter in, and then we'll make a start. I'll take the opportunity as well to just share next week's talk. So next week we'll be looking at mental health. So obviously a really important topic for LGBT people. This is, no, not that link. This link is the link to the registration form. Same one as always. It will be same time and place. So on the 26th, is it Wednesday 26th? Yes, Wednesday 26th, 8 to 9 on Medal. So go and have a look at that one and register for it if you haven't already. So as I say, we'll just leave it a few minutes and then we'll get going. Oh, and I didn't check actually. Can you hear me? Can you hear and see us? You should be able to see the front of Emily's PowerPoint on the screen and hopefully see both of us. If you could stick a yes or a thumbs up in the chat, just so we know we're not talking to thin air. Yes, brilliant. Thank you so much. Okay, yeah, like I say, then we'll just wait a few moments and then we'll get going. Okay, let's get going then. Just before we start, we'll have a QR code at the end of the PowerPoint with a feedback form on, and I'll send the link in the chat as well. As ever, if you could fill it out, that'd be really, really appreciated. It makes a big difference to us. But I'll hand over to Emily, and thanks very much.
Hi guys, I'm Emily. I'm a medical student at the moment in my final year. And today I'm going to be talking about social factors that impact LGBT healthcare. So I'll start by kind of just introducing the topic, then we'll talk a bit about intersectionality, and move on to talk about, I kind of labeled this safeguarding because there's not really a good umbrella term, but basically this will include some discussions of domestic abuse and homelessness and some challenging topics. And then talk a bit about substance use in the LGBT community and then kind of summarize. So we'll start with introducing the topic. So this whole kind of thing revolves around the concept of minority stress, which is kind of defined as chronic stress due to the discrimination or stigmatization that you may have because of your minority characteristics. So in this case, being queer. So it can lead to poor physical health, mental health, etc. So we won't be talking about physical or mental health in this talk really, because that's kind of been covered or will be covered in the talks throughout this series, but we'll focus in on more specific issues like substance misuse and homelessness, as I mentioned. So, and to define intersectionality before we go on to talk about it, so that's kind of the way in which multiple forms of inequality, different characteristics interact and overlap and compound themselves. So, for example, racial discrimination and homophobia can compound to impact people even more than each of them individually. So yeah, in general, it's really important to be aware of how social factors can impact LGBT health. Obviously, as doctors, often we can't do much about those social factors, but it's really important to be aware of them and take them into account when treating patients. So yeah, we'll talk a bit about intersectionality. So just to clarify, with this kind of topic of intersectionality, I'm not going to focus on every single type of intersectionality because I could talk about that. We could talk about that for hours, but I'm just going to bring up a couple of examples of different characteristics that being queer can interact with. So first of all, in terms of age, so this has been slightly mentioned in previous talks, I believe, but yeah, so particularly I'm going to talk about the older generation. So it can come with issues of isolation. So a lot of older queer adults are likely to be single due to multiple factors, including, kind of more homophobia in the past, just generally. They're also more likely to be estranged from their family. And so they develop a family of choice, which is essentially, picking the people they want to be close with, friends and etc. But keeping those close bonds can be challenging as they age, and so it can lead to loneliness and isolation. There's also slight issues with the accessibility of queer spaces for older adults. So the kind of typical, I guess, thing, the typical spaces that you might think about as young adults, so gay bars or kind of social groups, don't always cater for older adults all of the time, and there's not always a space for specifically older adults to come together. So that can lead to kind of isolation from the community. As well as this, there's kind of the aspect of sexual health. So it's often a lot less discussed in older adults, but it's important to remember that 50 to 60% of people with HIV are over 50. So it's kind of one of those things where you don't really end up discussing sexual practices with older people often, just because of, I guess, that assumption that older people are having less sex. But it's important to still be discussing safe sex practices and changing of sexual partners with older adults. And that's kind of a more general point, but it's specifically relevant for queer older adults as well. And then in terms of screening, so this is more in terms of transgender older adults. So this, we need to make sure we're doing the correct types of screening. So particularly relevant is breast cancer screening and aortic aneurysm screening. So because of the way that the systems work, so if you're a trans woman, you won't be flagged up to get automatically invited for an aortic aneurysm screening. but you need that screening because the risk of aneurysm is from the assigned male at birth characteristic, not from they don't think it's to do with testosterone or anything like that. So even if you've been taking feminizing hormones, etc., you need to get that screened. So that's just an example of something to think about with trans older adults as well, to make sure they're getting that screening. Next, we'll talk a bit about how race interacts with being queer. So in general, BIPOC people, so basically anyone who's not white, is 20% more likely to experience homophobic abuse online than white queer individuals. So just in general, that's kind of an increased thing, and partially there's kind of, I guess I said lack of community. I'm not really sure that's the word, but there's challenges within the communities that they belong to. So, for example, in the LGBT community, there is still racism. There is still, obviously, quite often white queer people are the dominant voice. And a lot of people will experience racism on dating apps. That's a very common thing that people will find. Yeah, about 50% of BIPOC people have experienced racism from other queer people. And it's also important to remember that people might experience homophobia in different ways, or in different ways, or more excessively depending on their community. So statistically, in general, more Black people have a kind of homophobic viewpoint than white people. Just based on statistics, that's the kind of trend that is seen. And there's a lot of kind of debate about why this is and etc. But the point of it is that it means that within their community, Black people are more likely to experience discrimination. And also they're 83% more likely to experience homelessness due to being kicked out because of their queer identity, which we'll discuss a bit more later. But it's just something to be aware of, that community is at higher risk. And then in terms of health, so there's barriers to healthcare in this community. So there's a lot of mistrust and a lot of assumptions can sometimes be made by healthcare professionals. This kind of applies to both their kind of queer identity and their BIPOC identity, and so that compounds to make any assumptions worse or more predominant. And also there's quite a significant issue with mental health, as with all queer people, but particularly in terms of eating disorders actually is more common in Black gay men than in white gay men. That's just statistics that's true. So there's a couple of different challenges, I guess, than amongst white queer populations. And then there's kind of an aspect that's surrounding. So this is more specific, I guess, and maybe slightly less relevant to the kind of UK population as a whole, but in terms of kind of appropriating identities, you might have heard of the phrase of Two-Spirit, which is essentially a pan-Indigenous term which is adopted by some Indigenous populations to describe people with both masculine and feminine traits. And it's kind of been over kind of history, been kind of suppressed by European kind of homophobic and transphobic ideals. And now it's slightly a topic of contention because some non-Indigenous people have started to claim this as an identity, and it's kind of appropriating that identity from Indigenous populations. And it can also be seen as a way of kind of almost the kind of phrase of two-spirit can be seen as kind of trying to push the idea into the gender binary in a way, because that's kind of the translated kind of phrase, but in the essence of it is that everyone has a different identity and carries their identity differently, if that makes sense. But yeah, in essence, there's conflicts around kind of identity and so, and then moving on to talk a bit about religion. So this is obviously also a complex topic. So with, you know, some religions being more accepting generally, acceptance varying between different families, there being different interpretations of religious texts, etc. So again, a lot of complex nuance, which and then in terms of queer and religious people's relationship with faith, it can often be quite complex. So in terms of like, just based on stats, the majority of queer people are not religious, and those that have often had a period of shame or questioning surrounding their sexuality and gender for multiple reasons. So internalized homophobia is quite common in religious communities, often due to religious teachings and stigma. And obviously this isn't the case always, but as a general rule, there is more stigma within that population. And it can start very early in life and can linger for quite a number of years after leaving the environment, especially in what they call, I think they call it like high intensity, that's not the word I'm looking for, but essentially strong religious belief. And it can lead to shame, low self-esteem, mental health problems, and can have a kind of wider impact on life going forward, even after the person might leave that religious community, or might it can have a wider impact on their life after that. So such as issues with intimacy, avoiding relationships, things like that. So it can be quite a complicated thing to work through. And often people might need counselling or support groups to try and work through kind of some of that internalized homophobia. There's also obviously the issue of conversion therapy, which the majority of conversion therapy does occur in faith settings. It does occur outside of this as well, which is important to note. So just because someone hasn't been kind of brought up religious or anything like that does not mean that they can't have undergone conversion therapy, but the majority is in the faith setting. And so promises to ban the practice in the UK since 2018 have not really materialised, which obviously is not, is not great. And then I think the new government sort of recommitted to trying to do it again, but also that hasn't materialised yet. So hopefully something will change with that. But obviously the intention of the conversion therapy is to change your sexual or gender identity, and this can come in a variety of different types. So counselling sessions, ingesting different substances, threatening homelessness, being prayed over, even can go to the extreme of corrective rape. It can be very extreme, and PTSD afterwards is very common. It is a form of abuse in its own right, so it's very important to listen to people who've had these experiences and take them very seriously. So moving on to talk a bit about immigration status. So it's, again, this is a complicated issue, as really all of this talk is. In terms of claiming if someone does not have UK citizenship, then claiming a partner or spouse visa is kind of if your partner lives in the UK, can be a bit more complicated if you're queer. So you have to kind of usually you have to prove either that you're married or you have cohabited for 2 years. And obviously, if you are from a country that doesn't allow marriage or civil partnership between queer people, then that's going to be an issue. And then proving the 2 years cohabitation, well, it's quite hard to cohabit if you can't have a visa to live in the same country. So it can be quite complicated. And you have to prove that it's a genuine relationship, which obviously is quite open to interpretation. And if you happen to get, I don't think I've particularly heard of any case of this happening, but if you happen to get a person looking at your case who's homophobic, then I can imagine that would be slightly uncomfortable. Well, more than slightly, but yeah, so it can be complicated. And then in terms of asylum seekers and claiming asylum, so since 2010, being queer has been one of the things that you can claim asylum for. You have to have a fear of persecution due to your LGBT status, you must demonstrate a genuine risk of serious harm if you return to your country. This has kind of been quite complex over the past few years, especially because the UK Nationality and Borders Act has come in, which makes it even harder to claim asylum, as it asks for evidence of your sexuality, which is very vague. And they don't just take people on their word. You need some evidence, and it's quite hard to produce evidence of your sexuality, more than kind of just saying that, that there's no kind of belief on word. So it can be quite tough. And then if you do manage to claim asylum, or while you're in the process, there's lots of risk of abuse in detention centres. There's not really many trained staff, and it's quite difficult to access specifically queer support in those kind of systems. But in terms of and then in terms of gender recognition, it can also be quite complicated. So often the documents provided during the asylum process, highlight kind of misgendering of trans people. So there's no legal gender recognition really during that process. And there's a greater risk of violence and things like that due to the clash between an individual's presentation. So someone might be a trans woman and present as a woman, and then their documents are all saying male, and there can be an increased risk because of that discrepancy in their documents, and worries of accusations of fraud because of that discrepancy. So you have to wait until after you've had your asylum granted, and then apply for a gender recognition certificate in the UK as kind of the normal process. But you must get a medical opinion. You have to prove that you've been living in your gender for a certain amount of time. And that's quite a hard thing to prove for someone who's just moved from another country. They don't really have much proof that they've been living in their gender for X amount of time, because they've kind of, their whole life's been flipped upside down. And this is kind of another issue on top of that. So, yeah. And then in terms of providing support, there's a couple of different charities. It's all charity based. So Rainbow Migration, Micro Rainbow. These are just some charities you can refer people to who basically help with the asylum process and can provide safe housing immediately after that asylum process. Okay, so moving on to talk a bit about neurodiversity. So it's also called neuroqueer, which is a term I hadn't heard before, but that's the kind of blend of those two identities. So autism is, if someone is autistic, they're 8 times more likely to identify as LGBT, and it's a really high co-occurrence, especially in the gender diverse population. And in the past, there's been some kind of things about providing gender affirming care and some assumptions that being autistic means that they can't make decisions about gender. For example, there's the kind of stereotype or thought that autistic people don't have the social knowledge to understand gender, which is just not true. And in the past, I mean, I think still to this day, can be quite hard for some people to get past those stereotypes. And just a reminder not to make any assumptions about any kind of capacity to make decisions about any care, including gender affirming care, and that is not a reason that they should not get that care, obviously. But yeah, another kind of form of neurodiversity is ADHD, and that also has quite a high co-occurrence with being queer. And a thing that happens in a lot of ADHD, people with ADHD, is that you can get rejection sensitive dysphoria, which is obviously can make homophobia and transphobia, kind of those rejections, feel even more pronounced. So I have a note about that kind of aspect of it. And then in terms of accessibility, so it can be difficult for some neurodiverse people to access queer spaces. So for example, Pride celebrations can be quite overstimulating for some people, and it can be quite hard for people to access those spaces, and it can make people feel quite isolated if they then can't access those spaces. And just in terms of signposting, you can signpost people to local kind of queer and neurodivergent, kind of the crossover groups, which might be, if people do struggle in kind of more overstimulating situations, then that might be a space that they can go to meet people. Yeah, so that was kind of a slightly chaotic, very kind of quick tour of some of the intersectionality. And so we're going to move on to what I've titled safeguarding, but basically it's kind of the more serious topics in terms of we're going to discuss a bit about domestic abuse. We're going to discuss a bit about violence and sexual exploitation. So this is just kind of a warning that's what we're going to be talking about in the next section. Just a warning before we start. So the first thing we're going to be talking about is hate crimes. So 4 out of 5 queer people have experienced some form of hate crime. So there's a lot of different types of hate crimes, including physical attacks, sexual threats, blackmailing, verbal abuse, kind of a lot of different types. But yeah, about 80% of queer people have experienced some form. And violence can be quite common, unfortunately. So particularly transphobic hate crime is most likely to involve violence or threats. And about a third of respondents to a survey stated they've been physically assaulted in the past 5 years, which is quite, obviously a very significant number. And there's been an increasing rate of hate crimes. So as you probably heard on the news and things, generally hate crimes across all categories, so you can see the table here, across all categories have been increasing, but specifically in terms of the queer population, in terms of transphobic hate crimes, it's increased by 186% over 5 years. So that was the 5 years from 2019 to 2023. So there's been 2 years since then, which there's no kind of published data that I could find out about yet. So it could have increased even further since then. And this is kind of on a background of a lack of government support for the trans population. As you might have seen in the news, there's been a lot of withdrawal of support, support for young people, and there's been no real active plan to reduce hate crimes since 2020. There's been no actual plan. So yeah, it's not a great situation. And then in terms of kind of what we can do as doctors in the background of this situation is obviously listening to victims of hate crimes, inform them of their rights, the fact that this is, illegal, you can report this, your medical documentation can be used as evidence, in that if you, document everything they say, then it can be used by them as evidence. You want to let them lead the conversation, so ask them to tell you briefly what happened, then let them kind of tell the story and prompt them as kind of you go. Just the main thing is just make sure you document any injuries and anything they say which indicates any kind of violence may be due to kind of anti-queer ideals. That's basically the only thing we can do as doctors, really. And then moving on to talk a bit about domestic abuse as well. So around 11% of LGBT people have experienced some form of domestic abuse in the past year. And there's several, and this is kind of higher than this is to do with several different factors, kind of different, some different to the reasons why it may happen in straight relationships or happen to cis people. There's quite a lot of power and control kind of factors around why it might happen in queer populations. They're kind of more at risk due to kind of the general discrimination, and quite often within these kind of abusive situations, people might manipulate someone's internalized homophobia. They might threaten to out someone. They might withhold access to healthcare, or for example, again, going back to the discussion of intersectionality, if they are an immigrant, if they are reliant on them for their visa, for example, then they might threaten them with deportation, things like that. So that kind of power kind of aspect, which is kind of a theme amongst all kinds of abuse, has specific types that are specific to this population. And then in terms of disclosing, people coming forward and disclosing their abuse, it can be complicated, so that there's often a fear that they will give the community a bad name if they come out and say that this is happening in their relationships. And again, the fear of outing themselves, and as well as this, the kind of assumption by a lot of people that it's kind of heteronormative assumptions that it's a fight rather than domestic abuse. If it's in, for example, a lesbian relationship, people sometimes think that women can't be perpetrators. That sort of assumption makes it a lot harder for people to come and disclose this to people. There's also some more specific forms of abuse which happen within the community. So, for example, there can be honor-based violence going on, which essentially is to do with the fact that it's often by family. It's often to do with the kind of perceived shame of having a queer person in their family, and so they will perform some act of violence against them as a kind of honor system. And as well as this, some different kind of specific forms of abuse that can happen in terms of the trans population. There can be some quite nasty forms of abuse, including deliberately using dead names, kind of talking about their body parts, things like that. It's really triggering stuff that will kind of bring people down in a very specific way, and kind of systematically, harm them. So in terms of support, we want to be reaching out to different centres that can offer specific support. Obviously, within the kind of usual route of the hospital, we should be doing all of our usual kind of things, and in terms of offering people support and offering what we can do for them. But then some specific kind of queer support lines are Gallup, which is the kind of main LGBT anti-abuse kind of charity, and then also the kind of general National Domestic Abuse Helpline. So so moving on to talk a bit about sexual violence and exploitation. So again, a very heavy topic. So starting off with a bit of a discussion around some of the fetishization of people in the queer community, particularly, for example, transgender people. About 65% of respondents to a survey answered yes or maybe to the question, have you ever felt fetishized? So it's clearly a very common thing. It can be quite dehumanizing, can be very gender dysphoric and distressing for people, and it's often facilitated by dating apps where people can send off a message and not kind of see the reaction from that person and things like that. And for example, the kind of thing that might happen is a straight man being interested in a trans man, but then refusing to admit that makes him not straight, and the kind of whole thing around that. And then in terms of hypersexualization, this can happen particularly, for example, if someone is pansexual. There's kind of a concept of pansexual people being greedy. A lot of slut shaming can happen. And then from that, people can make unwanted passes at pansexual people due to this perception of them being kind of attracted to everyone kind of concept. So it can be, really distressing for people. And then just briefly touching on sexual violence. This is kind of, I previously mentioned this a little bit, and I'll kind of discuss further how to kind of help with this as healthcare professionals in a few slides, but just kind of the point that it's a very sadly very common experience amongst the queer population. And then just to briefly highlight the importance of thinking about the fact that child sexual exploitation might be happening, and this is often specifically happening in queer populations, as the grooming kind of side of it might be focused around the fact that they are queer, and the kind of acceptance of their identity by the perpetrator may kind of start that kind of grooming off. And yeah, there's quite a lot of misconceptions around it, in terms of the fact that people think it can't happen in queer relationships, or can't happen, this kind of can't happen to men kind of thing, and there's quite a lot of misconceptions. So yeah, if you ever suspect it, kind of follow your safeguarding procedures, and yeah. So moving on to talk a bit about homelessness. So 1 in 5 LGBT people have experienced homelessness. So again, quite a high proportion, and 1 in 4 transgender people have experienced homelessness. So it's a very kind of high number, and about 80% of people gave like family rejection, abuse, or being asked to leave as the cause for why they are homeless, rather than money issues or whatever it might be. So the kind of queer population is quite a vulnerable group, like whilst they're homeless, particularly. So there's quite a strong link between drug use and homelessness. And as we will discuss a bit later, there's already quite a strong link between being LGBT and engaging in substance misuse. So there's that kind of link is strengthened even further. And then there's a higher risk of discriminatory violence, so higher risk of hate crimes and sexual exploitation while being homeless than in the straight population. And then in terms of emergency accommodation, it's quite hard to find shelters, and about 60% of people said they were discriminated against when trying to access shelters. And sometimes homeless shelters will be single sex, and transgender people have been turned away from them before because of kind of they just have been turned away for transphobic reasons, for whatever reasons, and yeah, so it's quite hard to access those shelters sometimes. And then obviously there's a lot of fear around reporting stuff to the police, especially in the queer population, and reporting hate crimes that happen whilst being homeless is kind of very rare. Only about a quarter of hate crimes that happened while people were homeless are reported to police, so that's kind of very low, and that's kind of another issue which ties in with that. In terms of support for homeless people, generally, crisis is a really good one. And in terms of specifically for queer people, Stonewall Housing and AKT, all these kind of details of these charities will be on the kind of slides when they go out. But those are useful charities. And then moving on to kind of a general summary of safeguarding and how we can help in the hospital or as doctors. So ask, first of all, ask very explicitly if you are suspicious of any form of abuse, any form of violence, and if patient has previously stated they're homeless or no fixed abode, then you want to be asking about violence and drug use, etc., just because of that extra risk factor. You want to be making sure you document really thoroughly. So medical notes can be used as evidence if a patient decides to take something to court. So make sure you really document everything in detail, as well as obviously you need to document everything in detail for, the hospital and for safeguarding as well. So you want to document the full story the patient tells you, and every detail, and as well as details of treatment, details of their injuries, etc. And then you want to record the injuries, as I mentioned. So you want to make sure they're recorded in detail. You might want to suggest to the patient that they take pictures of their own injuries if they're thinking of reporting stuff to the police, so that they have the evidence of the injuries. In terms of sexual abuse, you want to test for STIs, test for pregnancy, take samples, give emergency contraception, and it's kind of best to refer them to a sexual assault referral centre wherever possible. And then kind of after those, you want to consider a safeguarding referral kind of at the same time as all of this is going on. So immediately refer if the patient's under 18, and if the patient is homeless or experiencing sexual exploitation, then they count as a vulnerable adult. So you immediately refer them to the adult safeguarding team. And anyone that you're not sure about, ask someone, does this count as an adult safeguarding referral? Obviously, let them know that you're doing this, let the patient know. And if they don't come under kind of a safeguarding issue, still highlight the support present, let them make a choice about what they want to do. And then obviously offer kind of specific forms of the support for queer people. So as I mentioned before, Gallup, which is this abuse and violence, anti-abuse and violence charity. Okay, so moving on to talking a bit about substance use in the queer community, because we've kind of discussed that it's multiple things increase its risk, including homelessness, which I touched on before, but this is the kind of specifics about substance use and misuse in the queer community. So first, we're just going to discuss a bit about alcohol use. So there's generally a higher prevalence of alcoholism and binge drinking in the queer population. So about 20 to 25% of the community have a moderate to severe drinking problem, compared with about 12.5% of the general population, so about 2 times more. And then potential causes for this. So the kind of minority stress theory, which I mentioned at the start of this talk. So this means there's an increased risk for negative health outcomes due to discrimination. So people might turn to alcohol or other drugs to cope with discrimination that they face, violence they faced, etc. There's also an idea that potentially some of the environments which might in queer communities might normalize unhealthy drinking habits. So for example, socializing at gay bars, etc. Although I'm not entirely sure about how much that is true, but this is what the literature said. So there's a question about whether that might also be the case. And then in terms of risk factors for alcohol misuse, so untreated trauma, which obviously is more common in the queer population if they've had experiences of homelessness, being kicked of domestic abuse, etc. That's kind of more common. And then poor mental health, which again is a thing that we know happens a lot in the queer population. So it's a very at-risk group. And then in terms of you assessing alcohol use as a doctor, then you want to use specific questions. It's kind of like this is basically the normal kind of alcohol screening questions, but make sure you're asking specific questions. When you're asking how much you drink in a week, and they say a bottle, then say kind of overestimate what you think. So if they say a bottle, then assume that it's a spirit. So assume that it's vodka. So a bottle of vodka. And then if they're like, no, wine, then you can drop down to that, but always overestimate rather than underestimate. So it makes them feel more comfortable to share. And assess for any symptoms of addiction. So withdrawal, tolerance, relapse, all those kind of classic symptoms of addiction. So that's kind of what you want to be assessing for. And then drug use is also 3 times higher in queer people than in the general population. So that's across all age groups, and that's across all drugs of abuse. So
Looks like we've lost Emily just for a moment. I would just give her a minute or so to get back in. She's just having an issue with her Wi-Fi, but should be able to get back in a moment.
hello, am I back?
You are back. Is it okay?
Sorry about that. I'm on placement and this place's Wi-Fi just decided to die.
I'm
Right.
glad you made it back.
Yes, I did. Okay. So yes, chemsex. So yeah, I was just talking about a bit about drug use, and this is kind of one of the forms of drug use that is quite common in the queer community. So chemsex is sex while under the influence of drugs such as methamphetamine, GHB, GBL, or methadone. So there's quite a complex number of reasons why someone might start having chemsex. Some of the reasons people talk about is a lack of support and inclusion, internalized homophobia, and kind of chemsex is a way that their inhibitions are reduced, and so they can kind of overcome that kind of internalized homophobia. And a first experience of chemsex may lead people to seek more experiences. So obviously there's quite a lot of safety issues around this whole thing. And there's also quite a lot of taboo about it, and people are often quite hesitant to talk about it. So the main thing we want to do as healthcare providers is be completely non-judgmental, and just be completely non-judgmental, because the main thing we want is to be able to talk to people about how to be as safe as possible, how to get support. So yes. So in terms of the safety issues around chemsex, so there's an increased risk of STIs. So obviously, as people are less inhibited, it leads to more risk-taking behavior. So people stop using condoms and stuff like that. So there's an increased risk of STIs. There's also a risk of overdose. So the drugs used can often lead to blackouts, especially if they're mixed together. And obviously, as with all drugs, it's kind of unpredictable as to their effects each time, and also if they're getting them from different people, they don't know the kind of exact amounts that they're taking. So yeah, you just want to educate patients about those risks and educate people on the signs of overdose and what to look out for in their partners, so that hopefully it will be more safe for everyone. And obviously addiction is also kind of comes into the same picture as with any drug. People can become addicted to chemsex as well. Another thing to think about is people might be using poppers, so alkyl nitrates. So they're commonly used often by gay and bisexual men to enhance sexual experience, but they can carry a risk of acute hypotension, especially if they're combined with things like Viagra. So again, want to be warning people about those effects, and want to be having that in our minds. And then there's the issue surrounding consent. So obviously, as it's kind of defined sex while under the influence of drugs, this is a very kind of murky issue in chemsex situations, as everyone is under the influence of drugs most of the time, but it's obviously very easy for people to lose the capacity to consent. Sometimes neither party can consent. Sometimes one can and one can't, and it's very kind of there's been a lot of situations where there's issues with consent in chemsex. Sometimes people might get spiked or given these drugs, not knowing exactly what they're being given, and then obviously there's a lack of consent there, and there's kind of a lot of complications in terms of at what point people stop consenting, because obviously everyone is already under the influence of these drugs. So it's a very murky issue, and needs to be talked about with people, and make sure that they're aware that make sure they're kind of leaning on the side of, you know what I mean? Like it's just a very murky issue, basically. And in terms of offering specific support to people who are having chemsex, there's a couple of different places. So there's a thing called Club Drug Clinic, and there's also London Friend Antidote, which are both kind of help with drug misuse and also specifically chemsex in the queer community. So just in terms of kind of support generally, in terms of substance misuse, you want to be educating people. So you want to educate people on the signs of overdose, so rapid heart rate and overheating with methamphetamine in the kind of chemsex situation, and what you want to do. And specifically in terms of chemsex, you want to highlight that you will not be in trouble if you call 999 if you're worried about someone. So because obviously there's a lot of stigma and there's a lot of taboo about this situation, and yeah, it's but you want to reassure people that if you're worried about someone and you call 999, you're not going to get in trouble for that, and that can, you know, potentially save their life. You want to tell them about long-term risks of alcohol and drug misuse, of course, and just educate them generally. And one of the things that's really important, especially in chemsex, but in drug misuse as well, is reducing harm or harm reduction strategies. So, for example, telling them about needle exchange programs where they can get clean needles, doing STI testing for people, including hepatitis and HIV, telling them to take PrEP if they're engaging in chemsex specifically. You can also offer referral to addiction services. So you can offer them referral to rehabilitation facilities. So this can be LGBT friendly or specialized services. Offer services, so Alcohol Anonymous, and offer referrals to mental health services, because often these things can come hand in hand. And then in terms of specific resources for substance misuse, there's AKT, Drink Aware, and Serenity Addiction Centres, which are all kind of specific for queer people. And that is the end. I appreciate that was I actually didn't put a summary slide in there. I meant to, sorry about that. So there's no summary, but in summary, yeah, that was quite a heavy presentation. Yeah, sorry about that, but there's quite a lot of stuff to get through. And yeah, please do feel free to ask any questions. The feedback form is there. Please fill it out. Yeah, thank you.
Thanks so much, Emily. And I'm glad you managed to make it back after the Wi-Fi issue. But yeah, really fascinating talk. And so many important things to be aware of, like safeguarding substance use, that you all come across when you're on the wards and trying to look after patients. Any questions at all, pop them in the chat. I'm sure Emily will be very happy to answer them. Otherwise, if you come up with any questions in the future, I'll put my email in the chat and I can pass them on to Emily for a response. So there's that one. Okay, so the feedback form, as Emily said, is on the PowerPoint slide, obviously. If you'd rather fill out a link, if that's easier for you just to click on something, then there's the link for this feedback form. Yeah, it'd be really helpful if you could. Yeah, there's that one. I got there just in time. It'd be really helpful if you could fill that one out. And as I said before, the session next week on mental health, the registration form is just up in the chat if you scroll up a little bit. That will be the same time and place next week. Okay. Well, if we've got no questions, then it's 9:05, so let's head off. But thanks so much again for speaking for us, Emily, and hopefully see you all next week.
Thank you.
Cheers.
Bye, guys.
Bye now. Bye.